Liam. Thank you so much for joining this discussion on Faces of Digital Health. We're going to talk about the NHS. You are someone that Jane Samaru, the founder and CEO of Somex, says knows a lot about the NHS. So I said we should talk because I want to give the audience a bit of sense of what's currently happening in the NHS. It was announced that a lot of people are going to get dismissed, so the money gets distributed more evenly directly to the service providers. But before we really dive into what's happened now, I want us to maybe explain how the NHS has been changing a lot in the last few years. It went from 200 commissioning groups to 42 integrated care systems. And it seems that change is something that is a constant in the NHS. So how do you see this new announcement? And maybe for those that don't know it, you can also describe it a little bit and add how is NHS organized in the first place?
So I've been in this world for 20 years now, right? And, you know, I think there's a lot of people at the moment who are just coming to the service and they're seeing these big changes and they're kind of like, you know, sort of like, but like, you know, I think, you know, to understand the NHS, to understand, like, and it's probably the same with any large complex system, is that it's kind of like a string of things that have kind of gone back and happened in the past. And you mentioned the commissioning groups where there was 220 something, 223, I think, over the time. Like that was the environment where I was actually scaling an organisation across the NHS and winning each one of those 220 commissioners. So, you know, at that time, I saw how difficult it was to win each individual area. But I guess it's interesting to look at the clinical commissioning groups, because the clinical commissioning groups were pretty much very quickly considered by everybody to be a dramatic failure. There was a health secretary at the time called Andrew Lansley. We can work out on how high on the geekiometer we want to go, right? But like, there was a health secretary called Andrew Lansley who put through a very ideological reform of the NHS, and actually arguably a very stupid one, right? In which he was trying to push this dichotomous system of competition and collaboration within the same thing, and like, you know, trying to basically see if he could turn NHS organisations into business units. And very like before the reforms, everybody knew that it was going to be chaotic, and then when we got through, it was very clear that it was a mess, and there was lots of things where they were
what was the mess?
So firstly, the way that commissioning worked is they created these commissioning groups across the country. But actually, if you took all of the lines of national frameworks, they all went around them. So you created local GP-led commissioning bodies that actually had no commissioning power. The only two, so they didn't have commissioning power in primary, they didn't have commissioning power in secondary, the two biggest areas. And then there was like community and mental health, where there were a few things nationally, but generally that's kind of the only place that they had money and levers. So for a long period, we've had a system where you've got a local system which is physically unable to actually do and change anything. They've got such small amounts of money, and there are so many held national frameworks, they couldn't actually change anything in primary. They couldn't get these divisions to work together because they didn't hold the pen.
Right. So in essence, the system was too fragmented. And I think it's also worth mentioning that there are around 200 or a bit more than 200 NHS trusts in the NHS, just so we, you know, have that idea on what it means to have 200 commissioning groups and why 200.
Yeah. I don't think it was necessarily always coterminous with them, but yeah, they're like, there would have been a bit around hospital centres. So at that time, basically, what the vision for CCGs was, they created an economic model to try and have like a parameters it would fit within. But actually what they wanted to do is to let 1,000 flowers bloom and to see if GPs would just take control of their local area. So they went up into these senior positions, they left primary care to run these systems, only to kind of realise that they were tiny organisations and didn't actually have any leverage. And, you know, as a systems thinker, levers is how we change systems, it's how we affect change. And so effectively they were kind of arguably powerless systems.
What can we learn from that experience according to your observation, so we know what healthcare systems should do?
So I think, you know, like the changes in the NHS has been like this long drawn out hokey cokey, or sort of like a design thinking exercise where everyone's diverging and converging going wrong, you know. And I think, you know, if we come on to talk about national bodies in a bit, we've had that same kind of expand and contract thing, you know. It's like, you know, parties coming in and turning the dial up and down. Like, I think the first lesson that we can probably learn is that for realistic change, for actual change to happen, you've got to have systems that actually have genuine levers and have the freedom to do that. And even with the new system, some of the challenges that we've had is that they haven't necessarily had lots of levers in order to make changes. Because, you know, for those who aren't following the news in the UK at the moment, we very much kind of got this almost Doge-like narrative that's kind of come out, where we're sort of saying, cutting red tape, we're bashing bureaucracy, we're taking down the gatekeepers of middle management who are too inclined to say no rather than yes. And, you know, it's very easy, and for media it's very easy to say that, but I think generally if you look at the levers in the system, what we've had is also a number of problems. Like, that's not incorrect, and I think, you know, we're at an age of institutional bureaucracy kind of being less and less viable, right? Like, the world's changing, and the more complexity that we've had, the more that health has changed over the last couple of decades has helped to prove that as well. But I guess it's very easy. It's very easy to create a system, to give it a mandate, and then to take all of its power away. And I think this is probably, as we look forward, going to be one of the biggest lessons that we can learn. Like, if you really want to affect change, you've got to set a big paradigm, big mission. You've got to try and get people to believe in it. But if you immediately tell them, weirdly, I teach this to the military in terms of disruption of systems as well, right? If you immediately tell them that they don't have the levers and the tools to do it, then it's inevitably down the line going to become something that gets, say, well, you know, that where the scapegoats in order to kind of say, well, where it went wrong, you know.
Yeah.
And unfortunately, that's governmental quite often.
It's easy to be, I guess, critical in retrospect. I think it's admirable, though, when you think about the new things that the NHS is trying when it comes to the reorganization. So we mentioned that then the system got consolidated into 42 integrated care systems to work more towards the integrated care. There's also 4 NHS bodies inside the NHS England, NHS Scotland, NHS Wales, and NHS Northern Ireland. This is also something that people usually outside of the UK don't think about. It's not just one NHS. So that's why it's worth understanding what does it mean when the government now said that, you know, the NHS England is getting cancelled.
Yeah, well, I suppose as the name suggests, NHS England has its purview over the NHS in England. And so, like, you know, if we take health and social care, Northern Ireland, Wales and Scotland, like, they tend to act as, you know, they're as kind of quite centralised systems, actually. Generally, they're been traditionally led by governments on the left, or sort of sub-governments, devolved governments on the left. So, you know, for these systems, you tend to have about 6 to 8 sort of local health boards, which are actually a lot further down the line, although there's a number of lessons that they've struggled with too. But, you know, I guess when we, and I don't want to in any way sound like I'm kind of dismissing Wales and Scotland and Northern Ireland, but the vast majority of the UK population lives in England, and the vast majority of care and expense and so on happens in England. So traditionally, because of the devolved, weird UK nature that we're a country of countries, you know, the NHS in England, so the Department of Health and these changes are very much happening to NHS England, but actually, if you look at the political landscape, we can probably see that this will have knock-on effects in the other devolved nations as well, although we're always slightly careful in the UK, because the more that we try and run those countries from London, the more likely it is that people will start pushing back and saying we want independence. And, you know, there's always that kind of balance in the UK of, like, you know, Scotland wanting to leave and become its own sovereign state. So
what do you expect of this change? So what I heard you say is that the reason this matters is because it's going to affect a lot of people. When I first saw the news, I immediately thought, only somebody that doesn't understand the complexity of healthcare would dismantle an organization, that employs 10,000 people. But then I heard that a lot of people in the UK are actually welcoming this change. So what's your opinion? And what are the realistic expectations do you think people can have around this?
Yeah. So, okay. We know, as Albert Einstein said, that the definition of madness is trying to do the same thing over and over again and expect different results. I think, if we look at where we are in the world, and I think in the UK, we have the far right kind of on the fringes trying to sort of nip at the heels of the government. Labour was hoping to have 2 terms, and now it's very possible in this world that we're in at the moment that they could be having to do a lot in 1 term. We've also got a number of other economic challenges that come from this, because you can't separate the plans for the health system around this, right? But I think in terms of these changes, look, I'm very sensitive to the fact that there's a lot of good people who are going to lose their jobs. I've got lots of friends in NHS England who I work with, but I'm going to be entirely honest. I've been a special advisor for NHS England. I've worked with them very closely and built a national organisation. I know that area very well. I know all of the different tiers pretty well in different senses. For various reasons, NHS England has largely been an ineffective organisation. We've had plan after plan and strategy after strategy and thing after thing getting started and stopped and created and trashed, and people come and people go. And I've seen this firsthand year after year after year. And I think as a result of this, we've constantly had uncertainty about what's wanted at the centre and what the plan is and the strategy. And, whilst we are a devolved system, that we have integrated care boards that are effectively kind of autonomous unless they're financially failing, which most of them are, then the centre plays a varying role in that. And so I'll be entirely honest, I feel that we need to devolve, and I feel that we need to stop over, I agree with the red tape and the governance on this one. And I can see why a lot of people will have concern about the system and, of course, the job losses. But at the same time, it hasn't been an effective organisation for many years. If you count on your hand the amount of serious successes and impact it's made, given the cost of it, I think it's quite exciting. The one thing that I'll add is that we are 2 months away from the strategy coming. So this has been handled really badly, that what we've got is a load of major, generally create a strategy and then you do the actions. Whereas in the UK, we've got all of these actions with a lot of political narrative, but there's a lot of question marks. And anybody who knows about the NHS will have to conclude and finish their statement. But the devil's in the detail, and depends what's in the strategy. Because I've got a lot of hope. I've got a lot of fear around what's going to happen, because everybody I talk to is still it's up in the Department of Health. There's a small team of people who are writing a strategy, and there could be really exciting things in it. There's a lot of ideas that are really exciting around pushing power downwards, driving accountability, working more closely with local populations and not up to this bureaucratic centre. Mm-hmm. At the same time, it could be, I suppose the analogy I've been using quite a lot is that it could be that we slash and expect that that's going to create the benefits. And, that our vision for the NHS is we talk about all the things we want, the juiciest cake with all the juiciest cherries on the Michelin star level, but then we sack off the bakers and the cake itself is supposed to be calorie free, and that it's just a pipe dream. So we're all asking that question at the moment around, well, so what? What's the detail around this?
Do you know how much money is expected to be saved with this approach? I'm just looking at some of the data that I could find, and it says, so the Independent published some data that the central admin cost is £3.2 billion. 2% of the total NHS budget. I don't know, what's your insight?
So the first thing that we in terms of savings, the NHS has a budget it sets every year, and every single year it overspends by around, this year it's projected to be £6.6 billion, right? So we've got this so it arguably it's £200 million, right? So, if you look at integrated care boards, I think the general spend is about 150 mil. million pounds, sorry, I'm speaking to an international audience, so 150 million pounds. And if you cut that in half, then arguably that would be around about 75, 80 million pounds. There we go. So
yes. Just so we can imagine a little bit easier, yeah.
Oh, that's perfect. Yeah, so if we take that, the government is seeking to half the spend within the centre, but obviously in the centre, like some of these jobs will carry over to the Department of Health. So arguably if you took that 3.2 billion, put it in half, and then maybe did some reductions in Department of Health, you'd be maybe talking a couple of £1 billion. So we're still about 4 to 5 billion pounds short of the overall target.
Yeah. What do you think, is going to happen with people that are now going to lose their jobs? Because I'm thinking a lot of, I can see that I saw, when I was working still in healthcare IT, that, sometimes people from the clinical practice that were working on digitalization projects would move into the NHS. So I think this is an opportunity for them to go back, because when it comes to digitalization and implementation, you need people who know how to do that. And those are usually clinical people that go from clinical practice and get upskilled specifically for implementation of an EPR, of an EPMA, or something else.
Yeah, like I think those who are clinical by background, like there will need to be clinical roles that continue. Like, I can't imagine that any of the areas would even dare to not have clinical roles in them. And also a number of clinicians, such as national clinical directors and stuff like that, tend to have part-time jobs because they work in clinical practice as well. So the challenge, I think, is like when we've had previous reorganisations, Tiasha, like what we had is people have just kind of moved from place to place, and there's usually somewhere else that they go. And I'm cautious about how I say this, because I know people who are working in NHS England might be listening to this. Although, I think it's probably best to speak the truth in this. This is, I suppose, an attack and reduction on non-clinical mid-tier jobs. And over the last couple of months, we've had pushes around reduction in admin staff. They're the ones that I worry about most, because they're going to be the ones who really struggle to find jobs. If you're a senior leader who has years of experience and you've been national director, you're going to find it easier than someone who's got an admin role, right? But I suppose if we kind of take these, like the local system is reducing. Trusts, so the local hospitals, are being asked to reduce. The national system, the NHS England, is being abolished. The Department of Health is being reduced, so there's going to be a sort of smaller core thing. The health tech industry in the UK is on its knees.
Why?
And because the NHS has been so ineffective for years, because we've had this sort of hierarchy devolved system. So generally the view in the UK is that the health tech system is really struggling. There's a lot of companies that have left the UK. There's a lot, like the NHS is a wonderfully attractive system, right? It's really attractive for many reasons. But we don't have, if you look, for example, at DIGA in Germany, although obviously it's got its own problems, we've never had anything like that emerge. We had plans come about a year ago, and that's all been trashed with the new government coming in, so as far as we know. So, generally, the NHS is like this confusing, hyper-localised system. And because we've had austerity and productivity pushed down from the previous government, it's been really challenging for there to be any money towards digital. So I think through various forms of mismanagement, we've not managed to create a really secure and viable health tech industry. It is possible in the UK, but it's not seen as attractive by, there's a lot of investors that are all pushing companies to leave the UK at the moment. So
do you think that the hospital tenders are also going to change? Because health tech providers sell to hospitals, and hospitals are the ones that do tender processes, that want to test the solutions before they sign longer term contracts. Yeah. And I also recently spoke with the CIO of the Cleveland Clinic London, which is not part of the NHS, but I thought it was really interesting when he mentioned that Cleveland Clinic in the US is doing a year-long pilot with 5 ambient solutions, and after that year they're going to decide what to take. And he also urged everyone, when it comes to AI, to really be mindful, to do pilots, to be careful, to be slow in essence.
Yeah.
when it comes to deciding what you're going to buy, which is understandable from the clinical and hospital perspective, but like from the health tech and vendor perspective, it's just a nightmare.
Yeah. To which many of the CIOs would say, well, keeping your business afloat isn't our problem, keeping patients safe is, right? As they would always sort of say. I think the hospitals are probably going to be the least affected group on this. I think also, like, if we look at the way that the top team is changing in England, in the NHS in England as well, like, they've just announced their top team, and it's all chief executives of hospitals. Like, yesterday they announced a load of them, with the exception of the chief financial officer. All of the main jobs are currently working as CEOs of hospitals. I think the writing's on the wall that the hospital is going to become ever more powerful and is going to reach more into other areas in the community. And so, like, I think the hospitals are, you know, like, if you go to an area like Cambridge or Oxford, where the big academic institutes are, they already have huge amounts of control and leverage over their local system because they're so powerful and dominant. And I think that will give us a direction of travel. So I think in terms of the tenders and process, like, again, with hospitals, it's always been a hyper-localized process. It's always been hyper-localized. Generally, you go to them, you have to win them, and then they say, what frameworks are you on? Like, are you on this framework? Are you on G Cloud and so on? And so, like, that's a secondary thing rather than a primary thing. And I think a lot of folks who are coming to the UK sort of go, well, what do we need to get on so we can be bought? Whereas, to be honest, it's like, who do we need to convince? And then how do we make sure that we're on something that they can use? So I think that's probably less of a thing. Although I'm also hearing rumours that there are proposals and plans to do a more centralised procurement function. But again, since they're getting rid of everybody, how do they do that, you know?
What do you think about the current landscape for health tech providers? You mentioned that it's, you know, quite a struggle for them to work with the NHS. In one of the podcasts you did in the past, what I thought was really interesting was the challenge of sustainable healthcare business models and the fact that companies, even with software, are going from one-time procurements to subscription models, but the funding that hospitals get for that is not designed in a way that it would support sustainable financing of these solutions. So, for example, you get you get a pocket of money, you spend that money on a specific software solution, but that also means that after 5 years, when that subscription needs to be continued, you're going to have a problem because then you need to find another pocket of money. So, where do you see the changes in that regard, and how can health tech companies be sustainable in this uncertain time?
Yeah, like, I had a big discussion with a number of sort of the thinking leaders in this community. I think we're all pretty much of agreement that, look, like, you know, if we just step back and look at any health system, right, the digitization that's going to happen in our society is not us just adding stuff. Like, no society can afford that, you know, no matter where they are. Like, and there has to be a point where we shift to make sure that is about shifting business as usual change, right? And it has to be that. It has to be doing good work to say, this is how you currently work. If you use us, then you can save money, you can be more efficient, you can improve your productivity. I think, if I'm honest, like, we've had a number of years, particularly since COVID, where we had a lot of companies that came in with investors that thought that they were going to get rapid returns and that everything was game for opening. And I think, you know, there's kind of been a narrative that's almost been driven by, you know, and I said that the NHS is on its knees, you know, that the UK health tech industry is on its knees. I think part of the problem is it's on its knees because a lot of companies have blamed the NHS, a lot of investors have blamed the NHS. But actually, you know, like, you know, I've worked with 60 companies, and many of whom I've helped to get contracts. But that's because we've done really good work to make sure that we're helping these organisations to think strategically around how they're changing certain elements. And if I'm honest, many of the companies that I've seen over the years have done a slither of that. They haven't done enough. So I think I'm actually really, like, generally, whilst we've got lots of change, I'm really positive about the ability to make case to organisations, because I think that they know that change needs to happen. But it's not a drop in, stick one person, tell them about your product, and then suddenly everyone buys you. Like, if that's the strategy, and I kind of did an intervention with someone I met the other day. You're sort of like, oh yeah, we'll think about strategy in the future. We don't, you know, their strategy was, who can we talk to? That's not strategy. That's winging it, right? Like I think the NHS is very possible, but that kind of needs us to raise our game. And I think this is where, I think there's a lot of agreement amongst the players who've been around for a while that means that hard work has to take place. And I think that investors and those who are funding these businesses need to say, we're going to win this by inches, and we're going to have to invest a lot and front load a lot to get this to happen. But like, I scaled a business to 100% of the NHS, and that was through diligent hard work and absolutely committing to understanding the system. And there's no shortcuts. There was no just have a chat with people. It took us 8 years to get to 100%, but we did. And we did that because we lived and breathed fitting into that system. That's just what we did, So, yeah, I suppose it depends on what expectation comes. And I think the investor community obviously plays a really big role in this as well, I'm aware I didn't answer your question around the financial model side of things. I kind of spoke a bit more around the culture and practice side. Do you want me to answer that one?
Yes, absolutely.
Cool.
Because I was just looking at how much the NHS spends. And the UK spent, in 2022, it spent 11.3% of GDP on healthcare. And what I continuously wonder when it comes to technology is that we keep claiming that technology is going to save money to the system. But like, if you look at the business models and the cost for software, it's just, IT budgets needs to increase, and I see an increasing cost. So what are your observations in that sense, and how do you see that, promises around the return on investment and actual results go together?
Yeah, and it's a difficult balance, right? On two sides that want to kind of have their cake and eat it, because I think it comes down to who's taking and holding the risk, right? Does a tech company go, well, here's some stuff we've done, and you take all the risk, you pay all the money, and we'll hope that the outcomes come in the future, right? Or is it a system that says, we want you to take all the risk and to do this? Now, one of the things that has been emerging over the last few years, look at that, still not as bad as the US, right? It's insane. And our outcomes are still better than the US, right?
And this is definitely not, I would say, the right figure. I'm pretty sure that the US is now at more like 20%, 18 to 20 than 16. But anyway, let's say it says OECD stats, so we will trust the OECD. Yeah. But go ahead. We got distracted.
I can't look at that model and not think that people who don't have a good income in the US and get cancer are possibly going to be dragged into poverty. And I'm so proud of the fact that even though we've got a challenge system, that doesn't happen here. And I'm just really, really scared that that's where we're going to lead if we don't get things right, which is a total shift away from what the question was, right? But like, one of the things that's really interesting is that over time, there's been something called the NHS payment scheme. And it doesn't apply to everywhere, because I think what we've had is, obviously, we've had a pandemic, right, which has kind of thrown a few things up in the air. But the NHS payment scheme has slowly been moving towards giving more power to local systems in order to have different kinds of payment models with their providers, right? So obviously, you've got local system and the different providers. You might have two acute hospitals. You might have you might have a community provider and a mental health provider. And increasingly, the NHS payment scheme means finally these local areas have commissioning power in order to say, well, we're going to pay you a little bit for activity. We're going to pay you for KPIs, for key performance, things that are improvements. And actually, we're going to pay you based on value and so on. And like, what I think is really interesting is that it's quite clear that over time, and like NICE, for example, have just started changing their model to think about value, although it might be a bit ahead of the game. It might create some problems because they're thinking too far at the moment. But like, that actually, the ideal reality over the next 3 to 5 years is that this scheme starts to lead to folks going, well, we'll pay and we'll share the gains, or we'll do it based on performance and targets. And we've got the data and digital infrastructure in order to properly measure that. Because actually, realistically, philosophically, if I'm paying my taxes, why does the NHS go to a hospital and say, we'll pay you on performance, and they go to a tech provider and say, we'll just give you a flat fee, you don't share any of the risk? And so I'm really curious, and like the investment community is not my area, but I'm really curious about how how that works in the UK, because I heard recently about some American provider that came over and said, basically, we'll only charge you if you achieve these things. We'll take on the risk and we'll come and do this. And I think particularly some of the big tech firms that kind of come in and start being able to kind of get coverage and almost monopolize the system because they've got enough capital in order to take on that risk might become really attractive. So what we might start seeing is the system goes to the provider, and rather than going to the system and saying, can we have some money for this technology? You go to the provider and say, you're probably being paid for this, and we'll come in and share that risk agreement, and we will kind of be part of your approach that you're putting up. What's your model? Okay, well, how about if we take responsibility for this element, and this means that it can be more efficient and you can get more in terms of your KPIs. So I could see stuff like that's going to emerge. But again, we've got a brand new strategy, which will massively affect this. And, who knows whether the thinking around this is going to be good or not, like whether it's going to cover this at all, like it should. But, again, we're waiting and seeing on that one.
In the past, one thing that has happened in the NHS was also that there was the structure of two digital agencies in a way, NHS Digital and NHS X, and kind of nobody really knew what the difference was. So they just cancelled NHS X and now there's just NHS Digital. How do you compare that structure and that decision to what's happening now? Well, actually, if you're really going to go for digital, we also had Health Education England, who was responsible for digital skills training. We had NHS Improvement that had a bit of a role. Like, we had all of these bubbles of agencies kind of sitting around. Like, just to give a bit of perspective, so NHS England was always sort of the centre point. But then what happened was NHS Digital almost became like the tech delivery arm of it. So they would do stuff around the app, they'd do stuff around integration, or they would at least tell us they were doing stuff around integration. It's still not fixed. And, there'd be a number of sort of technical activities that they would do, such as email infrastructure and Teams and working with Microsoft. So that's kind of what they did, right? And then when the Health and Social Care Secretary, Matt Hancock, came in, I think he was quite frustrated by the fact that he couldn't really influence thinking in NHS England, because NHS England had a separation between the government. You can't just go and tell NHS England what to do, or you couldn't. And so his answer to that was to create this whole new organisation called X, which was supposed to be this like edgy design thinking. It was like the thinking about digital arm. So you've got an operational centre, you've got a different organisation that thinks about it, and a different organisation that does the technical stuff. I don't need to probably comment that that's quite dysfunctional and logical. And actually, so when the pandemic came, I was leading part of the response to where digital could be used in medicines, and I was kind of working in X. So I was drafted in and sort of did some work in NHS X during that time to sort of help provide responses. And we were trying to interface with NHS England to say, well, here's all of these different things that we could potentially do for vulnerable patients and stuff like that. And they were like, well, this is our plan and here's the rules and this is what we do. And there was no way that we could influence that. So we just ended up finding stalemates across the board. And that was my personal experience. And, we just ended up sort of and NHS England didn't like NHS X because they were taking response. They were just doing, supposedly doing duplication. So we had a bunch of mergers and they kind of brought them all back together. But then actually that was a huge number of job cuts. And like, what I know was happening in the background during this time is there was lots of political infighting and turf wars around, well, who owns this territory and who does that, and lots of job cuts and distraction, which again is why the organisation struggled to get stuff done. And, Do you think it's better now when there's just NHS Digital? Do you think is it more efficient?
No. Like, pretty much since 2019, we've had distraction after distraction and new health secretary and someone changing the rules and moving stuff. We've had a major reform. We've had mergers. We've now got a Labour government that's come in. And we also had that period before an election where everyone kind of stops doing stuff because they know a new government's coming in. Like, are they more efficient? Well, do they cost less than they did? Well, if you take consultancies out, there's a huge spend in that area, then they cost less than they did during the pandemic and maybe just before the pandemic. But obviously costs skyrocketed during that period. But I guess, are they efficient? Well, like, you've got to be able to measure the output in order to measure efficiency, right? And the reality is that the output's been bugger all. So if you take the output, the efficiency is probably more marginal. You know, it's a very hard organisation to measure because it's always had something it's going through, which is hugely distracting and loads of change. So, you know, it's difficult to answer that question, really.
Could it be that now people are excited just because this is a big change with the NHS England, you know, going away, and there won't necessarily be as big of an impact as people might hope?
I think there's definitely going to be an impact. I think the government wants to rule how this change happens. They don't want to give it away to another body where they're not accountable. There was an interview on Sunday with the Health and Social Care Secretary, and you know, he was like, how can I take responsibility for this if I can't actually influence anything that's happening, right? Like accountability needs to sit with me, and I need to be able to do that. And some separate body is just something for people to hide behind. So, again, it has to come back to what's the strategy and what they actually plan to deliver, right? Like, you know, and again, that leaves us in this middle ground at the moment. I think there's a lot of people who are excited because they like the idea of shit getting done. You know, they like the idea of just finally, right? There's others who are saying this is an absolute catastrophe because they think NHS England is a necessary model, and actually they've only been in the system whilst NHS England's been there. So it's kind of like, you know, like cutting something that's always been there out, and that will create fear. And of course, those who've got friends and close relationships and maybe have been reliant upon NHS England and are despairing because they might have lost perceived opportunities. I wouldn't go as far as saying that I'm excited. I'd go as far as saying I'm curious and intrigued, and there's a degree of hope that actually something really good could come out of this. But since I'm not in the central room, it could just be a bunch of noise and hoping that cuts gets an outcome. It won't.
It's definitely a big and heavy discussion, I guess. But like, since you mentioned excitement, you're kind of reading my mind, because I wanted to ask you, to lighten things up, what are you excited about in what you do, and in what you do with the companies, in what you do, you know, on the UK market? What's, you know, brightening up your day?
After the previous things that we've discussed, it's a good phase shift, right?
Exactly, good point.
we're covering it's hard to go through so much geekery and kind of it not be like a heavy damning thing, right?
So what's for dinner?
I don't know. Whatever I'm going to go and cook when I go downstairs after. What am I excited about? Like it's difficult to not have a degree of nervousness and excitement, but I feel that we are like, what a time to be alive, right? What a time at this moment, you know, and we can look at this in a number of areas, right? Like, we are going through this huge, very exciting revolution. People like you and me are in places where we can influence this. We can actually have an influence on how we shape future society. This is not the slow crawl from thing to thing. This is like stuff happening, you know? And, you know, whether you're at HIMSS talking about key things that's going on, or whether I'm in it, like, you know, a few weeks I'm chairing a convening session between a bunch of finance directors and tech companies to try and see how. I'm excited about that, because I think actually we've got over this kind of, we've had this kind of collective mourning, and now we've got this feeling of urgency. And as someone who's been teaching about the urgency for years, it's hard not to be slightly thrilled by the fact that we're here and now's the time, you know. And I can't help but being, you know, really, I don't know, really privileged to be in this place at this moment. But at the same time, there's a lot at stake, right? There is a huge amount that's at stake. And, you know, like my mission in the world is I want to try and see how I can work with others to see how we create a positive, productive, human-centric alternative to the Trumpian Doge model and you know, in our system, right? How we can positively and empathetically disrupt and change our paradigms in how we bring in we create a whole new system of health and social care, and that's super exciting.
Yeah.
So, you know, speeding out and looking at the bigger picture, I think I'm also just like for years, like I wrote a few articles on just like the hype cycle. Like for years, when I've been working with health tech companies, all I've been able to do is to say, this is how I see success looking. It's hard work. You've got to do the right stuff. You've really got to embrace this, and you've got to be sophisticated. And I think 2021, 2022, maybe even 2023, everyone was like, oh yeah, pots of money drop in, you know, everything. And now I'm actually excited by the hard work. I'm doing the real work. And now that everyone's a bit more sober, this, like, the harder the market kind of gets, the more I get excited that actually people are receptive to doing really good work. And I love the fact that I have longer term clients that I'm working with who are winning, and we're doing the best work of our lives. And it's really getting into that transformation that has to happen in the system. And that's really, like, it feels really fulfilling that after years of kind of everyone kind of being, oh yeah, but maybe another pot of money will drop or something like that. And, you know, kind of seeing the system as easy. Like, I've spent 20 years in the system. I know it's not easy. But it's winnable. It's absolutely, you can absolutely make change in a system. And so I like the fact that as a community that is kind of coming, because that means that I'm less compromised and more philosophically oriented. And in the UK, I guess, as someone who's arguably seen as, you know, a well-known leader in this area, it's nice that I'm getting so much better reception to what I'm advocating for too. So lots to be excited about, and slightly scared.
I will follow up with you in a year or so to see how that excitement is panning out for you and where the NHS is. But Liam, for today, I think we covered a lot. Thank you for all your thoughts, all your insights, and good luck with, you know, further endeavors and changes that are a constant in the NHS.
Thank you very much. It's been lovely to join you.